Hi everyone. This is Vivek Kulkarni with USMLE RX, and in this lecture, we'll finish up the cardiovascular section by discussing pharmacology. There are a lot of drugs to know when it comes to the cardiovascular system, but this information tends to be very high yield on the exam, so let's make sure to go through it carefully. We'll start with a brief discussion of anti-hypertensive therapy. In the case of essential hypertension, a number of drugs are used in order to lower systemic blood pressure. Diuretics, ACE inhibitors, angiotensin II receptor blockers, and calcium channel blockers. These are covered in greater detail in the renal section. In the case of heart failure, the classes of drugs that are used are again diuretics, ACE inhibitors, ARBs, but also beta blockers in compensated heart failure and potassium-sparing diuretics. For beta blockers, it's important to remember that this must only be used in compensated heart failure. If the patient is unstable and in decompensated heart failure, beta blockers should not be used.
Just to review, heart failure is considered compensated when physiologic adaptations in the heart and blood vessels allow cardiac output to be maintained, whereas decompensated heart failure is an unstable condition in which these adaptations are no longer adequate and cardiac output begins to fall.
Also, they are contraindicated in cases of cardiogenic shock because they decrease cardiac output even further, and in the case of cardiogenic shock, this could lead to worsening of the disease or even death. Next, although diabetes mellitus and the drugs used to treat it are discussed in greater detail in the endocrinology lectures, the numerous drugs listed here are used in diabetics to prevent long-term cardiovascular damage. Also, of note, ACE inhibitors are used in diabetic patients to prevent diabetic nephropathy. Now let's move on into a more specific discussion of some of the drugs that act mostly on blood vessels. First is hydralazine. This is a drug that works to vasodilate, and it primarily acts on arterioles. Since arterioles largely determine mean arterial pressure, hydralazine can be used in the context of severe hypertension or hypertension during pregnancy. Additionally, since vasodilation of arterioles lowers the afterload on the heart, hydralazine can also be useful in heart failure. It works by increasing intracellular cyclic GMP, which leads to smooth muscle relaxation, a mechanism that's very important for you to understand. Notably, it has a prominent side effect of tachycardia that results as a vasovagal reflex from decreased blood pressure. Often beta blockers can be used to help prevent this. Other toxicities that you might encounter are listed here. Next is calcium channel blockers. These drugs block the L-type calcium channel found in cardiac and smooth muscle cells. They decrease the contractility of both of these muscle types. Some drugs, like nifedipine, act primarily on smooth muscle, whereas other drugs, like verapamil, act primarily on cardiac muscle. Therefore, nifedipine is primarily used to lower blood pressure, while verapamil is primarily used to lower contractility. Some drugs, like diltiazem, have effects on both tissues. As a result, this class of drugs can be used in many clinical scenarios, including hypertension, angina, and arrhythmias, and also Prince-Metal's angina and Raynaud's disease. Side effects are numerous, but important ones include AV block, peripheral edema, and flushing. Others are listed here. Now we'll discuss some of the treatments for malignant hypertension, also known as a hypertensive crisis. The goal of therapy in this case is to quickly reduce blood pressure to prevent the likelihood of strokes.
Nitroprusside is a very short-acting drug that works via nitric oxide release, which increases cyclic GMP and leads to vascular smooth muscle relaxation with subsequent dilation of blood vessels.
However, it can cause cyanide toxicity if given in too large a dose or too quickly. Phenoldiprem is a dopamine receptor antagonist which causes vasodilation of renal vasculature. And finally, diazoxide opens potassium channels, which relaxes vascular smooth muscle due to hyperpolarization. Additionally, because of the relationship between serum potassium and insulin, which is covered in greater detail elsewhere, this drug can also lead to hyperglycemia. One important clinical fact about malignant hypertension is that the goal is never to lower blood pressure to what would otherwise be considered normal, that is, around 120/80. Instead, the goal is to lower blood pressure to something like 140 or 150. At this level, the likelihood of stroke is much less, but the risk of decompensation in the vascular system is also much less. Now let's move on to a group of drugs commonly known as nitrates, which includes nitroglycerin and isosorbide dinitrate. Much like nitroprusside, these drugs cause the release of nitric oxide in vascular smooth muscle, which leads to vasodilation. However, these drugs act primarily on veins, not on arteries, which leads mostly to a reduction in preload rather than afterload. As a result, these drugs are used most often in the setting of angina, but they can also be useful in the setting of pulmonary edema and occasionally as erection enhancers. However, drugs like sildenafil have largely taken over this last role. Common toxicities include reflex tachycardia, hypotension, flushing, and headache. This can also manifest as Monday disease in the case of industrial exposure to nitrates. This is not something you're likely to encounter clinically, but it is something that may come up on your exam. Now that we've talked about all these different classes of drugs, let's review how to best combine them in treating angina. Since angina stems from a mismatch between myocardial oxygen supply and demand, the goal of all anti-anginal therapy is to reduce oxygen demand in the myocardium. There are a number of parameters that can allow for such a reduction. Let's discuss each class of drugs and the effects that they have on angina. First, nitrates, as we previously discussed, work by decreasing preload on the heart, which can be measured here by end diastolic volume. As a result, they lower myocardial oxygen demand, and they also lower blood pressure. However, they can cause a reflex increase in contractility and in heart rate, leading to a decreased ejection time. On the other hand, beta blockers work by decreasing the afterload on the heart, which also decreases blood pressure and myocardial oxygen demand. However, they also have the effect of decreasing cardiac contractility and decreasing heart rate, leading to an increased ejection time. As a special note, pindolol and acebutolol are contraindicated in angina because they have partial beta agonist activity. When these two classes of drugs are combined, the overall effect is a marked reduction in myocardial oxygen demand, which is the whole goal. There also is a decrease in blood pressure and a decrease in heart rate, but there ends up being little or no effect on end diastolic volume, contractility, and ejection time because the side effects of the two classes of drugs tend to cancel each other out. That's why the combination of a nitrate and a beta blocker is so frequently used in the treatment of angina and something that you'll almost certainly run into in clinical practice. Also, as another side note, calcium channel blockers have effects on angina that are dependent on where they act. Calcium channel blockers that act mostly on blood vessels, such as nifedipine, have results similar to nitrates because their mechanism tends to be similar. On the other hand, calcium channel blockers that act primarily on the heart, such as verapamil, have results similar to beta blockers because, again, the mechanism tends to be similar.